This is a pre-recorded case by Dr. Gandhavadi, who is joining us virtually. On my panel, I have Dr. Sommer, Dr. Sanders, and Leslie joining us as discussants, and I think Nasir might join, we'll say. He's missing right now. But Maheer, I see you're on virtually with us. Welcome to Western AF, and thank you for joining us. Maheer's going to show us a case on beyond PVI using a high-density mapping system with efficient PVI and posterior wall ablation using 122 electrode mapping and PFA catheter. Maheer, the stage is yours.
Thanks, Devi. Thanks to everybody for having me and allowing me to participate virtually. Really appreciate it. As Devi said, we'll be talking about this 122 electrode mapping and PFA catheter. Here's my disclosures. So here's the PFA landscape. I think a lot of us have already seen this slide, basically looking at what the predominant FDA-approved offerings are in the PFA space. And everyone has different features. And the one that we'll be focusing on today in this case is the Cardium Globe system. And I think the one that what sets the Globe apart from other vendors and other products in the PFA space is that you have a catheter that is something that provides high density mapping as well as PF treatment. And not only that, it's very much customizable and configurable. So you're able to take real-time contact information from the catheter and then decide which electrodes are actually going to be delivering energy based on that information. And really, aside from the spline selection in a Volt catheter, the degree of customization that you see on the Cardium Globe is really unlike anything else on the market. One of the things that always comes up about the Globe is its size. It just seems like a really, really big catheter and a big tool. And although the French size is a little large, 20 French, the Globe itself is about 30 millimeters. So it's essentially comparable in diameter to a 31 millimeter pentaspline catheter FARAWAVE in the flower configuration. So the way the Globe works is it's essentially that it's a globe that you maneuver in the atrium, and instead of what we're used to, which is where you take a catheter and put it out the veins to create pulmonary venous anatomy, you're using negative space in this instance. And so what you're doing is as you move the catheter throughout the atrium, you'll see that as you reach a vein, you'll essentially see a dark area where there's no contact, where none of the electrodes are in contact, and that space is where your pulmonary veins are. And then you can choose your electrodes to treat the pulmonary vein or whatever structure you're treating in whatever way you see fit. And so if it's a vein, you can take a circumferential lesion. If there's an area with no contact, you can kind of segment and pick the areas that you want. If you have a focal AT, you can just pick 2 electrodes. That's the kind of minimum, is you take a pair of electrodes. So you could take 2 electrodes and just treat a focal AT that way. And then if you have a linear, more of a macro-reentrant rhythm and you need to create a linear lesion, you can essentially create pairs of electrodes and just select them to create a line as you would with any other catheter. So you have a lot of choice as you're doing it. And because there are 122 electrodes on it that are constantly evaluating points, you end up with maps that are generated fairly quickly. One of the features about this system is its design, and I think the engineers and the team has really put a lot of thought into the actual design of the catheter. And so the way it's designed is you essentially have a gold electrode, but it's on the outside and it's essentially shielded on the inside. So when PF is delivered, it's delivered only going outward from the gold electrode. And because you can see exactly which electrode is in contact and choose only to treat from the electrodes in contact, then you're preferentially delivering PF to the myocardium, and you're avoiding PF in the blood pool, which, as we all know, minimizes that risk of potentially getting hemolysis or other problems. So before we get into the case, I just wanted to go over the workflow just a little bit. And so the way the cardium works is they essentially have a flow map and a contact map, and that's what sets you up for your lesions. So the flow map is essentially real time. As you're moving your catheter around, you see on the catheter when it's in contact with tissue. So it starts to turn white when it's in contact with tissue, and it's black if you're not in contact with tissue and you're in the blood pool. And essentially what it's doing is it's measuring the cooling of the electrodes as they come into contact with tissue. So this is nice because it provides you a very quick real-time assessment of your contact. Once you're in a good spot and you think to yourself, okay, contact looks good here. I think I'm, abutting the left superior pulmonary vein, so I want to treat here. Before you do that, then you can essentially transition over to their contact scan. And so this is a lot more precise. And essentially what all the electrodes are doing is they're emitting tiny amounts of radio frequency. And the radio frequency uh, and the rate of electrode heating when that radio frequency is delivered is being measured and then calculated to create contact metrics. So then you know exactly where your catheter is in contact, and it may look like it's in contact initially, but when you run the contact scan, you realize, oh, actually half of this catheter isn't in contact, or it'll confirm, and you can see this contact map of the left superior pulmonary vein. It's nicely encircled here. So that gives you the confidence that you're ready to treat. So for pretty much every lesion you'll deliver with this system, it's a flow map, contact scan, and then you deliver. And usually it's a single treatment and you don't have to apply multiple treatments. You just let the pulses run and then you can move on to the next site. So again, here we have a flow map just showing the real-time changes, but then the contact scan confirms the contact. And then you can see the voltage before. And then once we deliver, all of the EGMs have disappeared. And then the voltage has turned red. So if you just keep your catheter in that location for a few seconds after each treatment, you're immediately able to see the change in voltage and confirm that you've delivered voltage everywhere you were hoping to deliver, and that you delivered a circumferential lesion as you would have desired in this case for the right inferior pulmonary vein. And then just touching on the Pulsar IDE before, I think this is the last thing before the case itself, but this was the IDE for the globe system. And I think just the key things were that when they looked at the veins, and 95% of them remained isolated. So it looked to be a durable pulmonary vein isolation. The success rates or effectiveness were in line with most of the other pulse field ablation treatments we've seen for treatment of atrial fibrillation. And then there were really minimal safety events. I think with the size of the catheter and the sheath, the biggest worry is that individuals may have vascular complications or fistulas, things just from the size of the apparatus. But if you see in the IDE trial, there was really nothing. So there was no bleeding, no vascular access complication. The only complication was actually just a hemorrhage, was not just, but was a hemorrhagic stroke. So again, had nothing to really do with the system itself or the size of the system or the sheath. It was, and the sheath and delivery system themselves have been fairly safe to use on the IDE and then also in our experience. So I'll just move on to the case. So this is a 77-year-old man with persistent atrial fibrillation. He had been on propafenone and failed attempts at rhythm control, and then was transitioned to amiodarone by the time he had this ablation and was in sinus rhythm on amiodarone. His EF was normal. CHA2DS2-VASc score was 5 due to hypertension, heart failure with preserved EF, and then coronary artery disease. And then those are just some case metrics. So we spent about 28 minutes in the left atrium, and then for the time to do pulmonary vein isolation and posterior wall isolation, it was about 15 minutes. So here's the start. So I think one of the first things you notice is that this is not your typical setup. And so I would say that the structure, the apparatus for the globe system reminds me a lot of what is being used by our structural heart partners when they're doing MitraClips or other valve interventions. It kind of has that feel to it. So it's different than what most of us are used to seeing or maneuvering, but the system actually handles very well and it's pretty easy to use. A lot of it is really just gentle steering. And so you can see here, we've got the globe catheter inserted under ice. And then we just turn the knob and the array deploys. It basically comes stacked and then it opens up into a globe and you can watch all of that very easily on ice.
Maheer, can you comment a little bit on where your transeptal location is and what you're doing for your transeptal access for these cases?
Yeah, so for thanks, Davey. So for transeptal, I usually tend to go pointing towards the left pulmonary veins. So I think the goal is really to make sure that you have enough space anteriorly and posteriorly. Some folks have tried to go even further towards the rights, but I find that for our purposes, we've just been pointing towards the lefts. And then when you deploy the sheath or the array and the globe comes out, I think that's where you want to make sure you have enough room anterior and posteriorly. And so usually I'll kind of position it in the center of the atrium and make sure that we're not deflected or pointing too far in one direction or another. For the transeptal itself, we've been using the radio frequency wire and going through the globe sheath itself. And because the globe sheath is deflectable, it's been very easy to maneuver it onto the septum and then just go across with the RF wire. The sheath is designed in a way that the transition is incredibly smooth. And so there's really no resistance across the septum, even for a sheath that's 20 French. So it tends to go across very, very nicely. And it's nice not to have to exchange one sheath for another.
Parsh, you got to experience the sheath for the first time and the system for the first time this past week. Any thoughts on how the sheath performed?
Yes, I mean, I agree with what Maheer just said. I mean, it was impressively smooth across the septum, something I didn't expect when I saw the sheath. So that was really impressive. I thought it was a fluke, so but 2 cases, right?
Yeah, I mean, I think we've been pleasantly surprised at the lack of resistance. It really just kind of glides across. It's and you wouldn't necessarily expect that with a sheath that's big, but it really does just kind of glide across the septum. So really the next step is just making atrial maps, and because the system has so many electrodes, it makes maps very, very quickly. And you can collect 12,000 points in a minute, but the key is that the maps that you're creating are from points that are in contact. And so it's only going to collect points when the flow map actually determines that you're in contact with tissue. So you're not going to get a bunch of false points or points from somewhere else or far field points. It's really taking the points when the tissue is touching the catheter.
I think it's important to understand on that previous picture, Maheer, if you can put there's 2 ways of looking at the map. One is looking at the mapping system that gives you the atrial map, and those veins are just renderings. No, we're not taking the globe catheter into the vein. You see where the vein is during flow map, and it's just a rendering. And then you can see the same thing on the globe as such. So you have the voltage map, or you have the atrial map where you can see it's like a globular map. You have to kind of get used to that. But then also the array itself shows you voltage, shows you the electrodes. So it's two panels that you can simultaneously watch.
Yeah, I think it's just a different way of thinking and looking at everything, because you end up with so much information and multiple ways of looking at it, but it's very useful. And so if I'm trying to focus on the catheter and where the catheter is moving, and I'm really kind of got my eye set on the catheter, I can just use the voltage around the catheter that's being shown up in real time, rather than having to kind of think about the whole atrial map. And then, as you said, as soon as you deliver a lesion, then you immediately have the change on the catheter itself. You don't have to create a whole new map to see that the voltage has been altered by the pulse field treatment. So here's the workflow again. So in this patient, this was their left inferior pulmonary vein. So once we felt like we were in contact with the left inferior, and you can see a circumferential rim of contact, then we took a contact scan to actually confirm that the tissue was in contact. And so then once the contact scan is done, you see that the tissue, there's a ring of white, which is contact around the left inferior pulmonary vein. And so then it's reasonable for us to treat, and then you can select the area. You don't have to select all of the white areas. You can pick and choose. So if you feel like some of this is getting a little too anterior, you can take away the anterior stuff. If you're planning to spare the posterior wall, then you can keep your lesions a little tighter so that you don't create a tiny isthmus on the posterior wall. So there's a lot of customizability here. So here's our example here. We've got the catheter into the abutting the left inferior pulmonary vein. We run our contact scan, as you can see, and then we select all of our electrodes. And so once we've selected the electrodes, then we can come on, but you essentially choose pairs of up to 64 electrodes in order to treat, and it can be as few as 2. Once the treatment is done, the EGMs you can see disappear immediately, and you can immediately see that the voltage has changed from pink, purple to red. And then we do the same thing with the superior vein. And I would say with what we're used to doing with catheters is really moving them, deflecting them, doing a lot of big movements. With this catheter, it's a lot of small, tiny movements. So everything is just kind of moving everything gently, small movements, small deflections, often taking off deflections. From cryo days, we're always used to being so coaxial with the catheter and trying to get that cryo balloon super coaxial with the vein in order to occlude it. But here, because the entire catheter is full of electrodes that can deliver energy, you actually don't have to do that. So you can be off axis, you can treat the veins from the side. It doesn't have to be this super coaxial thing. As long as you're encircling the vein, it doesn't matter which part of the catheter is doing it.
Philip, you've had access to a lot of pulse field ablation systems, and you've had your hands on many systems. What's your first impression as you see something like this that is high density mapping and contact assessment and ablation at the same time?
Yeah, first reaction, of course, is it's probably the holy grail. We finally found it. I did about 50 cases with this device as well, so also with the RF generation, so the initial one. And I think there is probably much more in that system than it currently shows, because what we are seeing here, and the case is excellent, is PVI and posterior wall. But keeping in mind that this catheter potentially offers 122 electrodes with nice electrograms, I think there probably is a lot more in it, like putting some algorithms on it, looking for sources, sinks, rotors, whatever, directionality of the wavefronts, conduction velocity. You could do so much more, like we have catheters with 16 electrodes, and we are completely excited about the quality of signals and information we get. And this tool has 122, so I think there's a lot more to come probably.
Yeah.
So this is a question to you as well as Maheer. Maheer, how many cases you did with this?
We've done a little under 20.
And you like it?
I do. It's been very good. It is different, like you see, but
What else you use?
so we have I use Afera, FaraWave, and we also have Veripulse, and
You use everything. You use everything.
yeah, we try to use everything.
Because I'm talking to Philip about this. I was introduced this with an RF version. And it's everything we're doing here. This is it. I mean, all in one solution. And the mapping is coming back and the advantage. And what's puzzling me, why is this company is not more penetrated in the lab? Is it the price that Europe is scared of? Or is it the safety, which is, I don't think it's an issue. Why this company is still not everywhere like the others were penetrated? Doesn't make, because you have it all in one, as you said, and we still did not added the mapping potential.
I will say, I mean, the ID trial was presented this year, and it got approval well, 2020, mid 2025. I will give the company credit for doing it's been on an LMR phase with physicians. I mean, I was part of the ID trial. I mean, I got to access the system early on. I don't think Maheer was. Maheer, were you part of the ID trial?
I wasn't
no,
part of.
So there's momentum that's being built with physicians that have interest in acquiring the system and bringing it into their work portfolio, I would say. But you think about it, right? It's we all have all these systems. It's hard to bring another PFA system in. I am gonna tell Stefan it's time for you to reach out to Nasir.
So Leslie, do you use this? No. What do you think?
I think it's definitely fascinating that you can collect a lot of data and then you can basically do the pre-map, ablate, and you get a post-map almost immediately because then you get the voltage after you ablate. So it definitely streamlines the procedure really well. So I do have a question for the panel and Dr. Gandhavadi. So in people who have small atria, what do you find, what is your experience regarding like flexibility? Like, do you feel it's easy to maneuver the catheter with the big, with the big catheter? And also like, how often do you find yourself like, for paroxysmal atrial fibrillation patients, you were planning to do just a PVI, and how often do you have to end up doing the posterior wall just because you have like a very narrow channel after the PVI because of the big catheter?
Yeah, I mean, that's a just to get to Nasir's point, and then I think that's a really good question. So it's really hard, right? Because now there's this PFA bonanza, and all these small companies are trying to make it in PFA. But what's the problem is we have all these legacy companies in our EP labs. We have Biosense, we have Abbott, we have Medtronic, and the activation energy to switch to something totally new and different tends to be a lot higher, even if it has a lot of promise. And I mean, from a cost-wise, this is comparable to or less than a lot of the systems that we've got. So it's not a cost issue, but it's new and different, and there's that activation energy. And then if you don't necessarily have that interest, or you have the capital wherewithal to do that, then you're just going to kind of stick with the things that you know and are within easy reach, especially if most PFA systems work pretty well. I also agree that there's a ton of potential in the system, and they are looking at things like sources and AF drivers. So there's plenty more to come. But to answer your question, so for small atria, it works really, really well. And so if the atria is really small, there have been times that we've essentially isolated both veins at once with the globe catheter. So both left veins will just get isolated at once. But because you can do everything off axis, you don't actually have to worry about maneuverability. You can essentially just pull the catheter back and adjust it slightly, and you'll occlude one vein to another. And then you can choose your electrodes. So you never have to worry about the the channel being too narrow on the posterior wall, because even in a small atrium, you can essentially trim that that rim of PF to essentially 2 electrodes wide. And so you can keep it to essentially 2 electrodes around each veins, which is a very, very tiny area. So it's really difficult to inadvertently ablate the posterior wall in this situation, because you have so much control, as opposed to if you're using one of these other catheters where you don't really know where it's going or know what's in contact, and then you remap and you realize, oh my gosh, now the posterior wall is gone because this spline just basically took this whole thing out. It's a much greater challenge to inadvertently do that with this catheter.
Maheer, can I ask a question about EP endpoints for this procedure? Because you're not able to place this in the pulmonary vein at all. You can't do pacing maneuvers from inside the pulmonary vein. How are you judging isolation?
Yeah, that's a good question. So we're going to touch on that in a second. So I guess before I touch on that, I'll just show you real quickly. This is our post map, and essentially, as we were doing a post map, we realized that there was an area of the posterior wall that was still not fully treated. And so, because we can do everything from one catheter, map and ablate, we realized it quickly. We were able to treat it, confirm contact, and then remap, and the signal was gone. So as soon as we ablated in that signal, everything went from pink to red. But let me see if I have this for you. So here we go. So when you're done with the ablation, you can remap and you can get your voltage map as you normally would, but you can check for exit block. So the electrodes themselves pace off of the globe catheter. And so if you position the globe catheter at the ostium of the pulmonary vein, then you can pace from essentially a ring of electrodes around it. So that's what we'll do. It's not the same as putting your catheter in the pulmonary vein, but it's pretty close, because you're essentially antral and trying to stimulate from the pulmonary vein antrum.
And Prash, just to highlight, I think there's very good invasive remapping data, which also showed significant or very high durability at 3-month post-mapping. Maheer, can I ask you, you showed a case with PVI and posterior wall. Can you talk a little bit to using the globe in doing linear ablations, since you had brought it up early?
Yeah, I think you have a lot more experience in linear ablations than I do, Devi, and so I'd love to hear your perspective on that. But I think it's been very easy to map with the catheter, and I think once you use it a few times, you realize that you can essentially maneuver the catheter anywhere you'd like within the atrium pretty easily. And so going from the veins and posterior wall to the lateral aspect of the atrium or the anterior wall is very, very simple. And then if there are any tachycardias that come up, you can map them very quickly and then deliver linear lesions. I tend to use anterior mitral lines for mitral annular flutter, so that's kind of my go-to. But I believe you have experience with lateral mitral lines with this system as well.
I have used it in the lateral mitral line, but again, we don't have the invasive remapping data on that, and I think that's coming from Vivek's lab. But I think using it in the anterior wall it's easier than some of the other catheters that are out there, except for the medium footprint focal catheters. I think to me the selectivity of the electrodes is what stands out, because you don't have to destroy or have mass destruction. It's almost like you're very prescriptive with your lesion set. And I like how you can just do activation mapping. I mean, we had the last case we did for mitral flutter, we had you could actually see the entire circuit on the array. And it's really nice to be able to take one catheter and do it. Philip, do you have any experience with or any of the linear ablation sets?
Not really. I think I saw a couple of cases where even like CTI lines have been created using this device on a right atrial level. Theoretically, it should work pretty easily actually, because once you're in contact and you're going to see that you're in contact, you basically just select more or less a straight line and going to ablate it, and even can check for completeness of that line pretty easily, because you simply select a couple of electrodes beyond and above and can check for the completeness of the block. So there's a lot in it. What is really funny is that everybody considers this device to be at least 7 centimeters in diameter, probably because the cable is not super slim, or the handle of the sheath is not super slim as well. But still, it's around 3 centimeters, which is very much in the range of the other devices. So it feels big, but actually it's not that much bigger than what we have.
I think I want to kind of call in Prash, and I'm putting you on the spot because you got to do your first case this week. And if you look at the IDE trial results, I think the one thing that stands out is most of the operators, maybe except Vivek and some of the European operators, it was the first time we were using the system. And to me, having the durability data and having the success or efficacy data in the IDE trial with that amount of safety stands out in the hands of relatively new operators, even though the handle and everything looks cumbersome. Prash, what were your thoughts on using the system for the first time?
Yeah, so I mean, I think it looks like a big system, okay? So that's the apprehension going in. I think the key is it is a big system in there, and you have to move with small movements. I think that's probably the key to this. You do cover the whole atria very, very quickly as a result of that. So you don't need a lot of maneuverability to move from one vein to the other vein. And so I think there might be a 1-2 case learning curve there, but that was the thing that struck me the most, that although it was felt like you were going to have a lot more trouble positioning it, it actually positioned really easily and needed only small movements.
Andrea, do you have an experience with the cardio?
No, I don't.
So before you came, we were talking about it. You have all the way the case was presented. You have the whole atrium. You really selectively can 126 electrodes. You can selectively ablate reliably. I'm wondering why is this not very well adapted? That's the question I was asking. What do you think the reason is? Andrea?
Well, we mean that, I mean, yeah. Well, I think it was approved recently. And it's like the fifth device in US. So I think, you know, people with PFA, especially in small center, they have to make decision about what they're going to use. They're not going to be able to get everything that is out there. So I think part of that is driven by, you know, the timing. You know, I mean, but obviously, if it's a good device, eventually it's gonna, you know, this is gonna change. But timing, unfortunately, with this, with PFA, has been an issue, especially for low volume center, because they just cannot afford everything that's out there.
Maheer, we'll let you finish.
No, I mean, I think everyone's covered everything very well. I think it's a robust system here. There's not much here. I think this last image is just the, we already covered. Oh, backwards. So this last is just looking at the post-ablation map and then retraction. But again, it's once the map is done and we've confirmed everything, then we're able to pull the catheter out pretty easily. So it just kind of collapses on itself. You kind of unwind it and let it collapse on itself and then pull it out. So, I mean, I hear what everyone's saying. I think it's a really well-designed system, and not only is it well-designed, the team behind it is very well-intentioned, and they have put a lot of thought into it. And so I think it's definitely a worthy entrant into the PF space that's so far provided a lot of value for our patients.
Andrea, I'm just going to put you on the spot. Since you can have access to any system you want, would you get the system?
Well, I'll try, yes. I like a flexible system, and my concern is that the sphere is large, but I'm willing to try anything and then make a decision based on outcome, workflow. I think those are the two criteria that sort of encourage us workflow. I mean, the durability data are impressive, so that's certainly a plus. But the workflow is also something that drives some of the choice that we make.
So let me ask Leslie, you've been out 3 years. What do you think about when you choose your system today in your lab?
Well, currently, we only have Ferropulse, but
If you have a choice,
If I have a choice, I think it depends on like, okay, are we bringing a first-timer ablation patients or a redo patient? So I think this system is pretty good for a first-timer PVI and PWI for persistent patients. For redo, I would love to have like a Fira as that would be a perfect option for like redos and atypical flutter mapping, and then you could have both options for RF and PFA, depending on what you find.
And I think they're systematically collecting data on CTI ablation. There's also data that's being looked at in, each of the pulse strain is about six strains. So I think there's data being looked at, can we optimize the workflow even better? So there's a lot more to the system. And like Philip said, I guess it was initially an RF system. So, can that come back? Can it be a dual system in the future? So all of that has to be worked out. And I will not say the word rotor here, but I think, but just looking at, AF mapping and, because it is a large catheter, I think there might be things that could come in the future that are much, much more valid. Maheer, thank you so much for a wonderful presentation and enlightening us on the globe system, and for a great case. Thank you to our panelists as well for joining us on this.